Intravenous therapy. Intravenous therapy introduces liquid solutions and blood products directly into the bloodstream or areas that readily absorb these products into the bloodstream, such as the blood marrow, bone marrow. It will restore and maintain fluid and or electrolytes. It provides a route for medication administration. It allows for transfusion of blood and blood components and provides a route for parenteral nutrition. It provides direct access to the circulatory system, which provides a rapid drug action. It can achieve precise dosage calculation and flow rates. It avoids pain and tissue irritation from intramuscular or subcutaneous injections or oral drugs that may irritate the gastric mucosa or potentially even be inactivated by gastric juices. The dose can be titrated to achieve a desired therapeutic response. And with blood sampling, we can obtain blood samples from most IV access devices for lab testing. If we're drawing samples, for example, to determine therapeutic drug levels, like our peak and trough levels, we would draw our peak level after the completion of a dose. The interval between completing and obtaining that blood specimen would depend upon the specific drug. And then our trough levels are drawn prior to the administration of a subsequent drug dose, usually about 30 minutes before you administer that drug dose in case changes in the rate or dosage need to be made. Risks of IV fluid therapy would include bleeding, emboli, blood vessel damage, fluid overload, overdoses due to that rapid medication absorption, allergic responses or adverse effects, incompatibility to drugs and those solutions, catheter complications, interference with our activities of daily living, and understanding that IV therapy is more expensive than oral or intramuscular administration. With our pediatric clients, the younger the child, the greater the risk of fluid and electrolyte imbalances, fluid overload, and congestive heart failure. These clients have an immature homeostatic regulating mechanism. So the younger a child, the larger the body surface in relation to their weight, and that can result in quicker and greater fluid losses than the adult. The metabolic rate is about 3 times faster than in the adult, and that does increase their water requirements greatly. When we go to insert the IV cannula, that should always be done in a treatment room or a room other than their assigned patient room. That's going to allow the child to associate their bed and their room with comfort and security. We'll then use age-appropriate distractions to help take the child's mind off of the procedure. If we use topical anesthetic, make certain that it is in place for approximately an hour for full effect. For our younger children, we can administer an oral high sucrose solution, and that can be highly effective in pain relief. If possible, do not allow the child to see the equipment and prepare that equipment outside the room. Be honest with the child. Make certain they know when that needle is removed, and let them know why the procedure is necessary in terms that they're going to understand. Never tell the child that the procedure is not going to hurt. Instead, let them know that it is going to hurt a little bit, but you're going to be as quick as possible. You need to always have at least one other staff available to help restrain that child. And you'll usually restrain above and below the potential insertion site. The nurse frequently has to hit a moving target, so you need to be prepared for that because they're often going to move despite the restraint. And it's not recommended to have the parent be one of the persons that's helping restrain. Allow that parent to be the one that provides comfort. With children, it may require vein visualization tools to help find their veins because they have increased subcutaneous tissue. Following the procedure, be certain that you praise their behavior regardless of how cooperative they were, and allow the child to talk about or play out their feelings. You may not need to use tourniquets on children. You may just use the grasp of the assistant around the extremity. Make certain that you immobilize the extremity with a padded board in a position that is going to maintain normal joint configuration. The administration sets that we use with children are the microdrip, but use your electronic infusion devices to help reduce the risk of fluid overload. Different veins that you might consider in a child would be the dorsal hand veins, and those can be used for all ages. Avoid using the dominant hand or the thumb sucking hand, and realize that those IV sites will require splinting on the arm board. And it's probably going to interfere with the child's activity level. The dorsal foot veins can be used in pediatric clients up to walking age, and occasionally for an older child in case of trauma or burns. The antecubital fossa is generally unsatisfactory because that has to be immobilized. However, if needed, it is more favorable in the older child, and we should use the non-dominant extremity when possible. Always avoid the inner aspect of the wrist. Infiltration in that area can result in dangerous traumatic pressure on the radial artery and the radial nerve. The scalp veins are going to be readily available up to approximately 12 months of age, but they are preferable in infants that are 6 months and younger because the older they get, the more active those hands are. To dilate the scalp veins, you would place the head lower than the rest of the body, and that often is going to cause the child to cry, but crying along with that lowered head can help raise the scalp veins. It is difficult to distinguish those veins from the arteries in the scalp, so LPNs are not allowed to perform venipunctures in the scalp. And that IV site has to be well protected to avoid dislodgement. Central veins are going to be recommended for therapy that lasts longer than 1 week. We can do the percutaneous central venous catheters. We would use the jugular veins in the neonates and the infants, subclavian veins in the older child, and occasionally the femoral vein. We can also do the peripherally inserted central catheters, or the PICC lines, and that would be in the basilic, median, cubital, and cephalic veins of the antecubital fossa. With the neonates and the very small infants, we may be able to utilize the umbilical cord, and we can also use the large saphenous, the superficial temporal, the external jugular, popliteal, and axillary veins. So with our older adults, we need to understand the physiology of aging as it affects our IV therapy. Their immune system is going to go through some physiological changes. It will become hypo-responsive to foreign antigens, but hyper-responsive to itself. So it has a decreased number of circulating lymphocytes, and that results in decreased resistance to infection. With our pulmonary system, there's decreased subcutaneous tissue. There's also a decreased cardiac output at rest, and that will make the older adult more sensitive to fluid shifts with infusion therapy. Their total body water amount is decreased, and the older adult is at an increased risk for fluid volume deficit and or dehydration. Older adults have a decreased tolerance to fluid excess or deficit, but they can be very slow to show signs of those issues, and that requires the nurse to monitor them carefully for subtle signs. So with our older adult, fluids can be administered via the subcutaneous tissues or intravenously. The subcutaneous route is for fluid volume deficits or to prevent dehydration. We can also give some medications by this route. It requires insertion at a right angle to the adhesive platform that will then be pressed against the skin to hold it in place. Sites would include the posterior upper arm, the anterior or lateral thighs, and the abdomen, as long as it's greater than 2 inches from the umbilicus. Those sites have to include sufficient subcutaneous tissue to absorb the tissue or absorb the fluids. So if they're pretty emaciated and they don't have a lot of subcutaneous tissue, some of these sites may not be appropriate. Prior to insertion, you have to cleanse that skin really well, preferably with a chlorhexidine, and you have to maintain skin integrity. When administering fluids by the sub-Q route, you may need to rotate those sites every 24 to 48 hours. But when you're only administering medications through this device, the site can remain in place for up to 7 days. When you're using IV therapy, in other words, you're going into the vein, use the smallest gauge and the shortest length device possible to effectively deliver that ordered therapy. When you're selecting your site, avoid flexion areas, avoid areas with bruising. When possible, avoid that dominant extremity, avoid those small spider web veins, and avoid hard sclerosed veins that feel cord-like. Then palpate that vein and dilate it. You palpate it gently and understand that aggressive tapping can actually result in hematomas because their vessels are very fragile. Do not use a tourniquet if the client's hypertensive. However, if you do use one, lightly apply a tourniquet to avoid overdistension of fragile veins. An alternative to a tourniquet would be having an assistant apply digital pressure with the hand above the intended site and release it once that vein has been entered. When you insert it, the required angle of insertion may need to be decreased because they have diminished subcutaneous tissue, and that results in the veins being more superficial. Always apply skin traction below the projected insertion point, and the direct method of venipuncture with the older adult is often the most appropriate. When you stabilize the cannula, consider the older adult's skin fragility and use hypoallergenic or paper tape. Minimize the amount of adhesive that's used because excessive taping can lead to skin tears. With the site dressing, use transparent dressing when at all possible. It can help in stabilizing the cannula. It also will decrease accidental dislodgement of that cannula, and it assists in minimizing the use of tape on fragile skin. Site protective measures might be required for your agitated, confused, or restless older adults. Different site protection devices may include a long-sleeved gown, the soft hand mittens, flexible elastic netting over the site, a padded arm board, or commercially available IV site protection devices. Recognize that the older adult has a lower tolerance to rapid infusion, so care has to be taken to prevent runaway infusions. This would require the accurate setting of infusion flow rates and making sure that the roller clamp is inaccessible to the clients, especially if they're confused. So assessment, regardless of the age of the client, has to be ongoing. We're going to look for evidence of fluid volume disturbances, evidence of electrolyte imbalances. We're going to take accurate INO measuring Frequently assess the venipuncture site, and if an infiltration does occur, realize that the fluid might drain away from the cannula insertion site. So gravity, it might be lower rather than right at the site itself. We assess for evidence of the infectious process onset, and we assess for the expected therapeutic response to any drugs that have been administered. There's a variety of venous access devices available. We have the catheter over the needle devices, and that consists of a plastic catheter that's attached to a plastic hub. It uses a sharp needle as a stylet and helps guide the catheter into the vein. That catheter is going to be slightly shorter than the stylet, and then we remove that stylet following successful cannulation and leave that plastic catheter in the vein. We have winged infusion sets that are also known as butterfly needles. And this consists of a steel needle that is attached to flexible wings. And then behind those wings, there's a small administration set. Midline catheters that are inserted into the upper arm. They're considered a peripheral device. However, they can remain in place for 1 to 4 weeks. We have interosseous devices that deliver fluids and/or medications directly into bone marrow. We insert those into a large bone, with the upper anterior tibia being the most commonly used site, and we use a special drill type tool to insert. These devices are used during emergent situations when quick access of a peripheral vein is not possible. However, they can only stay in place for 24 hours or less, and honestly, they should be removed as soon as a peripheral site has been obtained. Due to pain with the infusions of an intraosseous device, it might require the administration of lidocaine into the marrow. And to insert these devices, it does require additional training. We have subcutaneous infusion ports, and these are used in clients that have a limited vascular access. They're used for mild to moderate dehydration and/or medication administration. These do require adequate subcutaneous tissue. This is what we would infuse in our older adults. Then central lines are placed into large veins near the heart, and they're intended for long-term use, the infusion of potentially caustic drugs or our total parenteral nutrition, multiple concurrent infusions, CVP or central venous pressure monitoring, larger volumes of fluid, and/or blood sampling. It does provide multiple lumens with one catheter and reduces the risk of peripheral vein irritation and prevents multiple peripheral IV sticks. Risks of central venous catheters would include a pneumothorax, infection, thrombus formation, vessel perforation, and air embolism with insertion, and it does require insertion by a physician. LPNs are not allowed to do blood sampling from central catheters. There's a variety of central catheters available. We have non-tunneled catheters that are inserted into the femoral, subclavian, or internal jugular vein. They're intended for short-term use in clients that require irritant or vesicant medications or hemodynamic monitoring. We have the peripherally inserted central catheter, or the PICC line, which is a central vascular device that's inserted into a peripheral vein in the upper arm, and then the catheter is threaded to an area close to the heart. It's used in clients that require therapy greater than 6 days. This device can be inserted by a clinician that has had specialized training. A tunneled catheter requires surgical incision. It's inserted into the chest, and it's used in clients that require therapy longer than 1 to 3 months. Then we have implanted ports that are inserted into the subcutaneous tissue in the chest, and basically it's under the skin, therefore it's implanted. It's used for clients that require long-term but intermittent therapy. It's accessed with a special non-coring needle that's in a right angle shape. This is called a Huber needle, Huber. It cannot be accessed by LPNs. Peripheral lines are going to be placed in the extremities, or in the case of an infant, in their scalp, and they are intended for short-term use. Therapies that are not appropriate for short peripheral catheters would include a continuous vesicant therapy, chemotherapy, parenteral nutrition, also known as TPN, solutions that have a pH that is less than 5 or greater than 9, or an osmolality that is greater than 600. Any IV cannula, needle or catheter, can be converted to an intermittent administration set by attaching a needleless cap or an extension tubing that has a cap. These are called saline locks. We use them for intermittent therapy and to provide immediate IV access. We avoid multiple venous punctures because of these devices, and it has a potential for a decreased fluid overload. They're also economical and provide increased comfort and mobility. However, if they're not flushed periodically with saline, clotting is a significant risk. These intermittent infusion devices can be left in place the remainder of a hospital stay following the discontinuance of continuous IV fluid infusions. To maintain our IV sites, a regular ongoing assessment has to be completed. Sites need to be assessed at least every 4 hours, and more frequently if it's a pediatric client, and that should be done at least hourly. Our critically ill clients, clients receiving sedatives, that have cognitive alterations, that have infusion sites at our joint flexion areas, those need to be completed hourly. Clients that are receiving vesicants and peripheral sites need to be assessed at least every 5 to 10 minutes. And assessment is going to involve assessing the IV site for our correct fluid, our correct flow rate and the volume of fluid, the expiration date of the solution, the dressings and the administration sets, dressing integrity, the site itself, and any client complaints. It's recommended prior to and after and in between infusions to flush the intermittent device with normal saline. So when you're locking it after the final infusion, you flush per facility policy. And understand that for most devices it's going to be saline, but some central devices are going to require heparin flushes. So follow the facility-specific policies for flushing. Document each flush on the medication administration record. Our dressing changes will be completed per facility policy. If it is a gauze dressing, it needs to be done at least every 48 hours. If it's a transparent dressing, it should be done about every 5 to 7 days. We can also do dressing changes outside of those parameters if the dressing is soiled, wet, or loose, or if we see signs of infection at the insertion site. Sterile dressing should be applied to all venous access devices. So refer to your clinical checklist for appropriate steps in doing your dressing changes. It's really important to maintain digital pressure to that cannula to help prevent dislodgement when you're changing the dressing. Central venous access device site care and dressing changes will require the use of a face mask on the nurse and the client unless the client is unable to turn their head, or if the client is able to turn their head away from the site, then they may not have to wear a mask. Clients that have the central lines at home need to be educated on the signs of infection and dislodgement, and when to report problems. Antiseptic solution, our chlorhexidine is the preferred solution. We do recommend prepackaged dressing kits when available. You have to use sterile technique. And then label that dressing with the date, time, and initials of the nurse that performs the dressing change, and document that procedure in the client's medical record. It's no longer recommended to rotate peripheral sites as long as there's no complications noted at the insertion site. If you do suspect a bloodstream infection, culturing the catheter tip should be a consideration. And placing our IVs that were placed in an emergency situation should be replaced as soon as possible due to the increased risk of introduction of pathogens during the insertion. Administration sets are going to be changed per facility policy, but can be about every 96 hours. Tubing that's used to administer blood might be changed with every unit that's infused, but at least every 4 hours. With total parenteral nutrition or lipids, we change that tubing about every 24 hours. And tubings need to be labeled to indicate when they should be changed. The IV fluid container should not be used for longer than 24 hours. Every nurse needs to be familiar with the agency needle puncture and body fluid exposure guidelines. Infection prevention needs to be in accordance with facility policies and procedures, in addition to federal, state rules and regulations. Personal protective equipment should be worn during all infusion procedures that potentially expose the nurse to blood and body fluids. The majority of the time, that's just limited to your gloves, but occasionally it may require something more intensive. With infection control measures, the nurse should reduce the manipulation of all components of the entire infusion system to reduce the risk of contamination. Hand hygiene should be completed before and after all infusion procedures, and no artificial nails should be used when performing infusion therapy procedures. Tourniquets and all insertion equipment should be single client use. Gloves should be used for catheter insertion. Make sure when inserting the skin is scrubbed with an appropriate antiseptic agent and it's allowed to dry completely to prevent chemical burns. Do not touch the skin after it has been cleansed unless you're wearing sterile gloves. Make sure each sterile dressing is intact. Understand that infection is going to occur more frequently in the nutrient-rich solutions like TPN and blood. Examine your equipment and your solutions for integrity and expiration dates. And remember, ongoing assessments will help find signs of infection early. And all IV injection caps need to be cleansed with 70% alcohol and allowed to dry completely before accessing. The safety measures are scissors. Scissors for IV therapy needs to be limited to suture removal or potentially catheter repair. They should never be used to remove vascular and non-vascular access device dressings, tape, or stabilization devices because of the potential of client injury. That may include digit amputation in infants, accidental skin lacerations, and accidental severing of catheters, and that would create an embolus. Safe handling and disposal. Make sure that all blood-contaminated sharp items, including but not limited to your needles or your stylets, your surgical blades, your syringes, should be discarded in your non-permeable, puncture-resistant, tamper-proof biohazard container. This does not include your discontinued saline locks. You never place those in your sharps container. You put those in the biohazard bag. If you can imagine trying to stuff your tubings and your catheter and the lock, etc., into a sharps container, you're risking injury by the sharps to yourself. And then all biohazard materials, wastes, and drugs need to be discarded in the appropriate biohazard containers. Complications of IV therapy can be local or systemic, and even life-threatening and life-altering. Be sure that you pull off and print your Complications of IV Therapy handout in your resource section on Blackboard. It's important to use appropriate techniques, frequent assessment to identify potential complications, and then implement appropriate interventions when you do suspect or see a complication. Prevention of the complications is going to be vitally important. Local complications can include infiltration, extravasation, phlebitis, thrombophlebitis, cellulitis, infection, occlusion, and nerve injury. And systemic complications can include air embolism, bloodstream infections, speed shock, circulatory overload, allergic reactions, and adverse reactions to medications. So infiltration, that's the infusion of non-vesicant fluids and or medications into the tissue surrounding the IV cannula. These clients may complain of pain or a burning sensation. That site may appear pale, edematous, hard, or cool to touch. The nurse should stop the infusion and elevate the extremity. The site will have to be discontinued and a new site obtained. Extravasation is going to be the infusion of vesicant fluids and or medications into the tissue surrounding the cannula. Inflammation of the vein wall is called phlebitis. Thrombophlebitis is the inflammation of the vein wall with clot formation, and it can be caused by irritation from the cannula or some medications. We might see or feel redness, edema, warmth, or the client may complain of pain. The redness may indicate infection, and this also requires discontinuation of the site and obtaining a new site. Make sure that you review the phlebitis scale that is located in the Complications of IV Therapy that is in your handout in the resources section. With infection, you might see redness along the vein or in the site area, swelling, purulent exudate, warmth to the site, and an elevated temperature. This does require removal of the catheter, and once again, consider culturing that catheter tip. Monitor the client and the IV system for excessive fluid volume. So use the flow control devices if at all possible. And always use a flow control device with your pediatric infusions. There is a device called a burette that the nurse places the amount of fluid that's to be infused over 1 hour in a chamber that's separate from the solution bag. So in the event of an infiltration, only up to 1 hour's worth of fluid would be infused into the tissue. If symptoms of fluid volume excess occur, slow down that infusion rate, elevate the client's head, and then notify the physician. And an embolus, that's a foreign object located in the bloodstream. It might be a blood clot, air, a piece of the IV catheter, etc. The client may experience shortness of air, hypotension, chest pain, and potentially shock or cardiac arrest. If an IV cannula flushes with difficulty, never force the flush because a clot may be dislodged. It's always recommended to aspirate. Understand that 10 mLs of air can cause an embolus. So monitor your infusion lines closely. If an air embolism does occur, turn the client to the left side with their head lowered. This will encourage absorption of the air into the right atrium. Notify the physician and administer 100% oxygen and keep the emergency cart close by. So these are the nursing priorities that can have the most impact on the client that receives IV therapy. The potential for injury includes trauma, infiltration, and extravasation. Potential for infection is from the cannula irritation, medication irritation, or non-adherence to the aseptic technique. Fluid volume excess can occur in clients that have impaired renal or cardiac functions, or basically any client that has an infusion who does not receive appropriate monitoring. And impaired peripheral circulation can occur from emboli or thrombi. And then finally, we're going to move on to termination of intravenous therapy. Now, usually we do require an order from the practitioner to discontinue an IV site, but that's only if we're discontinuing the IV therapy. Nursing assessments can indicate the need to discontinue a site, and that would be when we assess infiltration. The site is red, tender, indurated, or warm to touch. We see evidence of thrombophlebitis. The vein is hard and tortuous, and the client complains about the extremity aching. Site infection evidenced by drainage. Cannula occlusion. Evidence of cellulitis. Suspected IV-related sepsis. Product defect. Or the client just complains of pain at the site. Make certain that you put a description of the site in the client's medical record. So when you terminate a site, always inspect the cannula and visually determine if the length of the cannula removed corresponds with the length that's inserted as noted on the original documentation. And visually determine that the catheter tip is not jagged. Then provide appropriate client instructions. They need to leave that dressing in place for several hours. Avoid rubbing, scratching, or bumping the site, and notify the nurse if they note any renewed bleeding or they have pain or discomfort develop. And then document your education. If it's not documented, you did not do it. And record the appearance of the site, the condition of the catheter, and how the client tolerated the procedure.